All right, so I guess I will kick it off. So thank you for taking the time to join us for PQMD's Health System Strengthening Pillar Talk, Forging Ahead on COVID's Shifting Landscape, a part of a larger series of webinars which the PQMD community of practice cultivates to address major trends, leading thinking, best practices, and provocative issues in global health. PQMD is able to put these webinars together because of the strength of our coalition and the depth of the work our members do every day. We have been very fortunate to have the participation of some very insightful and knowledgeable people, and we look forward to you joining the discussion too. I'm Elizabeth Ashbourne. I'm the PQMD's Executive Director, and I want to welcome you on behalf of our entire team. For those of you who are not familiar with PQMD, we are a global alliance of international NGOs and leading healthcare companies committed to advancing the role of production donations worldwide. Founded in 1999, our work is guided by 5 pillars: humanitarian assistance, health system strengthening, disaster response preparedness, guidelines, and knowledge management. By virtue of our trusted network, our members leverage their partnerships, expertise, and resources for impact, all while adhering to the highest standards of excellence in donation practices. Today, the work of our members is central to the international response to coronavirus. Our members are focused on critical supplies, supporting healthcare workers, donating cash where most needed, and of course, strengthening health systems to promote sustainable access to quality healthcare in underserved communities and populations in crisis. So very quickly, I just want to review some housekeeping rules. So go ahead and warm up your fingers. Please type your name in the chat box and let us know your organization too. Because of the large audience, all participants are muted and videos are disabled. We do invite you to use the chat box for questions and comments throughout. And this session is being recorded. And I will share the PQMD's online community of practice into the chat box. So please be sure to join the timely and informative discussions with our members there as well. So now I have the pleasure of turning it over to Chris Skopec, who is moderating this session. Chris Skopec is the Executive Vice President for Project Hope, responsible for overseeing the organization's global health programs worldwide and leading emergency response. He has over 2 decades experience working in global health, humanitarian response, and development. Chris is also a board member of PQMD, currently serving on the executive leadership team as the assistant treasurer and secretary. Chris's extensive work in health system strengthening and his current role give him a truly global perspective on crises around the world, making him an ideal moderator for today. So thank you. And Chris, over to you.
Thank you so much, EJ, and great to see everybody here. Good morning and afternoon to all our colleagues. I'm going to start by stating the obvious. The COVID pandemic has dramatically turned our worlds upside down. But for those of us working in global health, the pandemic hits at the very core of what we exist to do. We've all seen, heard of, or experienced firsthand the demands on frontline healthcare workers, the shortage of critical supplies and equipment, and of course, the staggering death toll that continues to climb over a year into this pandemic. But the casualties of COVID go well beyond those immediate effects. The pandemic has been so disruptive to national health systems and to people's health-seeking behaviors that it threatens to reverse huge gains in progress we've seen around the world in strengthening healthcare systems. Now, while it's too early to assess the entirety of these cascading effects, early indications are alarming. WHO in Africa has reported both decreases in prenatal visits in many countries, along with increases in deliveries over the past year. Tragically and unsurprisingly, at least 10 African countries have reported a rise in maternal deaths. And this is after years, and in some cases, decades of steadily reducing rates. Similarly, UNAIDS recently conducted an analysis that showed that lockdowns and closures put in place to slow down the spread of COVID have greatly affected the production of antiretroviral therapies, putting the 24 million people who are currently on ARV therapy at significant risk of harm to themselves and others. For those of us involved in the global fight on AIDS, we know what a huge setback this can be. So even as we collectively work to end this pandemic, it's imperative that we keep our focus on the continuity and sustainability of our global efforts to support resilient and responsive healthcare systems. And to that end, we have an exceptional panel of speakers, each of whom plays a unique and essential role in this space. So I'd like to introduce our speakers, and I'm going to give brief bios on them, but please note that their full bios are available on the PQMD Community of Practice. First, we have Dr. Mohammed Lamor. He's the head of the Department of Global Health Security at the Infectious Disease Institute at Makerere University in Uganda. He directs several national level health security projects, including the Strengthening Partnerships for Preparedness and Response. He's also a member of the Science Standards and Regulations Technical Working Group for the Africa Task Force for Novel Coronavirus, and he's the past chair of the African Network of the International Society for Pharmacoeconomics and Outcomes Research. Next, we have Allison Neale, the Vice President of Public Policy at Henry Schein. Allison has worked in global health, corporate social responsibility, and human rights for more than 2 decades. Allison leads the company's public policy and public health engagement by partnering with government, industry groups, non-governmental, and intergovernmental agencies. Allison also serves as the chairwoman of the Gold Foundation Corporate Council and leads the company's engagement with the UN Global Humanitarian Action Executive Alliance. Lastly, I'm going to introduce Dr. William Clemmer. He's the Senior Technical Advisor for Health, Nutrition, and Humanitarian Programs at IMA World Health. Dr. Clemmer is a seasoned physician, public healthcare professional, and trainer facilitator with 28 years of experience in clinical care, healthcare management, health system strengthening, and assured delivery of essential healthcare services in some of the most challenging contexts in the world. Bill has spent most of his career living and leading healthcare programs in the Democratic Republic of Congo, South Sudan, and Somalia. Now, you'll note that you do not see Bill on the call today. Bill is based in Goma, where he's lived for much of the last 2 decades. And for any of those who have been watching the news, there was a very severe volcanic eruption on Sunday just outside of Goma. Over 1,000 homes were destroyed, 20,000 people were displaced from their homes, and Bill was making a very valiant effort to be available for this call, and as of this morning, he learned he's being evacuated himself. So he still hopes to join us, I think, which speaks to the humanitarian heart that he has, but we may not get his participation today. In any case, it is worth noting that IMA World Health is actively responding to the affected in Goma from that volcano. And I believe there will be a link to support IMA World Health efforts in that response through either the community of practice or through this chat group. So did want to make that note. But first, I'd like to just go to our panelists. And in this case, Mohammed and Ali, just an introductory question for you both, and we'll go in order as I introduced you. So first with Mohammed, can you just tell us a little bit about the work of your organization in strengthening health systems and how that was impacted this past year by the COVID pandemic?
Thank you very much, Chris, and it's a pleasure to be on this Pillar Talk. So the Infectious Diseases Institute is also known as IDI. It's part of Makerere University in Kampala. This is one of the oldest universities in East Africa, actually with the oldest medical school. It's about 20 years old as an organization. This is the IDI, and it was set up really to strengthen health systems. So, that mission to strengthen health systems in Africa with an emphasis on infectious diseases and operating through 2 main approaches, research and capacity development. We've been working mainly in HIV, TB, malaria for the last 20 years. Actually, the Institute was set up in response to the crisis of HIV in Uganda at the time. At the time, there was a need for increased capacity to provide healthcare. Antiretroviral therapy came subsequently. And so the Institute really set up large platforms covering the capital area, Kampala, the West Nile region of the country, and at one point, some other parts of the western part of Uganda closer to DRC. At a certain point, I think 1 in 3 people on antiretroviral therapy in Uganda were supported by IDI's programming, working with government and other partners. Now, about 5 years ago, we sort of made a strategic focus, and this really had to do with our experiences of outbreaks in Uganda, including Ebola, Marburg. Uganda has had quite a checkered history with numerous small outbreaks, Crimean Congo hemorrhagic fever. And strategically, we felt it was necessary to start to prepare for these health threats. Working with the government of Uganda, we were able to set up a program And we then received international funding from groups like CDC and Resolve to Save Lives subsequently to work in this area. The areas of work we had embedded for health security included laboratory systems. We also worked in district preparedness, really strengthening coordination systems. We also worked in, infection prevention and control, WASH, and case management. Those skills turned out to be very useful for our organization in times of crisis. And actually the build up to the COVID outbreak was the outbreak of Ebola in DRC. And so we had the 2018-2019 challenge of an Ebola outbreak in DRC. And then the districts in Uganda alongside that border with DRC had to step up preparedness for, in some cases, 1.5 years. And so the work we were doing from there was then leveraged for the COVID crisis. Of course, once COVID crisis came in Uganda, the government took a very aggressive and rapid response approach. And there were quite stringent lockdowns, more stringent than you would find in many of the other countries around us. Uganda ended up with quite a low number of COVID cases in the first 6 months of the outbreak. And as we speak now, a year into the outbreak, Uganda has had about 40,000 cases confirmed and about 350 deaths. What happened in the early stages was that IDEA had to find a way to continue its programming in HIV, TB, malaria, come up with innovative ways to ensure people pick up their drugs and make sure that, you have that registered. But at the same time, work very quickly with the government of Uganda to strengthen, for example, emergency operations centers. So sending personnel to support 24-hour coverage of situation rooms, working with government to actually bring out legislation that allows the government to place those rules that enable us to have the lockdown. But infection prevention and control, lessons from Ebola, were the things that really gave our teams the confidence, to go to borders, support screening, whether it's airports or land borders, support screening in national laboratories, and also to expand infection control practice in the health facilities around the country. So I'll stop there and forward to more.
Excellent. Thank you so much, Mohammed. And if I didn't mention it at the start, we welcome any questions that you want to put in the chat box, and we'll be monitoring that over the course of the hour. So Allison, if I can turn to you with the same question, please.
Sure. Thank you so much, Chris, for the opportunity to be part of this discussion today. Really honored to be with you, Mohammed, and wonderful to hear about the incredible work that you do. Obviously, we're thinking of Bill and hope he's able to join us, and hope that he's safe, most importantly. And also just want to thank PQMD. Henry Schein is one of the founding members of PQMD. We are so deeply grateful for the terrific and impactful partnership. My colleague, David Kochman, who's Vice President of Corporate Affairs, he serves as legal advisor to PQMD's executive board, and he, together with my colleague Jen Kim Field, our Vice President of Corporate Social Responsibility, represent us at PQMD. So just really pleased to be here and thankful for the partnership. With respect to our panel today, I guess I'll share a little bit about Henry Schein if you don't know about us. We're the largest provider of healthcare products and services to office-based physicians and dentists. We have operations in 31 countries, and we've been deeply involved with pandemic preparedness and response for quite some many years. In my role at Henry Schein, I lead our public policy and global health work. I've been with the company for 13 years. And as part of my work, I'm engaged in several public-private partnerships, which I think are relevant to our conversation today. One, Henry Schein was one of the co-founders, and we serve as the private sector lead of an initiative called the Pandemic Supply Chain Network. This is a public-private partnership that seeks to enhance global preparedness for pandemics from a supply chain perspective. And so as we continue our discussion today, I'd like to dive deeper into why that organization was founded and how it's operated over the last 6 or 7 years, and including in the pandemic. Also related, some of the other public-private partnerships that we're engaged in from a supply chain strengthening and a health system strengthening perspective we were one of the founders of the Global Health Security Agenda Private Sector Roundtable, which is a group of companies that have come together to utilize their core competencies to support health system strengthening and global health security. And actually, we have a partnership specifically with the Ministry of Health of Uganda. So it was good to hear of the work, Mohammed, in Uganda. We serve on the CDC Foundation Corporate Roundtable, and so through that initiative, also have the opportunity to engage in global health security together with the CDC and work through how the private sector can contribute to those efforts, specifically through the U.S. Centers of Disease Control and Prevention. We were also one of the founding members of the initiative UHC 2030. This was an initiative that I believe was founded at WEF. It was housed at the World Health Organization and now at the World Bank. And this initiative really seeks to find opportunities for the private sector to contribute to overall efforts of UHC 2030, which of course is focused on health system strengthening. And then with respect to the pandemic specifically, just one US domestic example, but I think will become relevant as we continue our discussion and think more about how do we strengthen global health supply chains and thinking about some of the challenges that we faced during this pandemic. Henry Schein serves on the U.S. Health and Human Services Supply Chain Task Force, which is a really interesting initiative, which, again, I'd like to discuss further as we continue our conversation. But I would say across all of these initiatives, the common thread is really looking for ways for the private sector to engage with governments, with NGOs across the private sector, so within industry and then across different industries, to and with the health profession specifically, to find ways to really utilize our core competencies as members of the private sector to contribute in any way that we can. And so, again, thank you so much for having me here today, and looking forward to the rest of our conversation.
Thank you so much, Allison. Henry Schein just plays such a leadership role in this space. It's really impressive. For those of you that may not be familiar, Allison mentioned the Pandemic Supply Chain Network. That includes WHO, the World Economic Forum, UNICEF, World Bank, CDC, as well as over 60 manufacturing and logistics companies. So it's really all of the major actors in this space, and they have had an absolute spotlight on them over this past year. So really eager to hear more about that, but also the fact that has a focus on the global supply chain, while at the same time you're part of the U.S. Supply Chain Task Force and understand some of the lessons learned there. So I'll look forward to coming back on a couple of those points, Allison. But Mohammed, what you described was extremely impressive. Firstly, I mean, the Uganda as a country, the whole of society approach, from the government-led policy changes to on the ground healthcare workers delivering on the response required for COVID, but not overlooking the needs in other areas of infectious disease, as you had pointed out, with HIV, with TB, with other very serious and very real healthcare threats to the population. You maintained that continuity of care. We've talked in this industry for years about the importance of localization, the need to decolonize aid. In this past year, we've seen countries around the world just apply the most strict protectionist policies to respond first and foremost to the pandemic within their national borders. The need to fast track these longstanding development goals around localization of aid seems to be more urgent than ever. Can you talk a little bit about IDI's model for investment in strengthening the capacity of the health workforce in Uganda, and really how that positioned you to respond to the COVID outbreak?
So thanks very much, Chris. I think we were very fortunate that certain investments were made at the time they were made. So from 2015 to 2020, through the US Centers for Disease Control and Prevention, I think, we need to just emphasize that investing in people to build capacity for preparedness can actually increase, the savings that you would have during times of response. So developing countries often don't have huge resources to mount massive, large outbreak responses. But if they have the capacity for preparedness and they're able to identify an outbreak early, then a small team can go there, identify the case, do contact tracing, step up prevention measures, and basically end the outbreak. And so that's the philosophy that we've been using with a very small, relatively small team, between 30 and 50 people, but well-trained and cross-trained. So biosafety, biosecurity, infection prevention and control, disease surveillance, including some of the newer models of electronic infectious disease surveillance and response. So having this, tightly knit, competent teams that work so closely with government, often embedded with government, means that at the time of crisis, you can quickly mount a small response. And so I can give an example that between 2015 and 2020, my team was probably involved in about 15 outbreaks, including Marburg, cholera, Ebola. And so when COVID-19 came, the description that was used was that the team was ready to go. And that's interesting because COVID-19 is very different from the other infectious diseases outbreaks that we'd had in the past that were more, contact precautions. This is droplet spread. Many ministry personnel would not have been very familiar with protective measures to use at the time. So having that team in-country meant that we could immediately start infection prevention control scale-ups. And I think a very interesting model that was used was a mentorship model. So we knew we had this gap across our health system. We didn't have respiratory pandemics before. And so we said, IDI, you might have this skill, but you can't go everywhere in the country. So we sat down with the Ministry of Health and called all the partners, similar implementing partners for HIV across the country, many of them strong presence in health facilities, and started the cascade of a mentorship program. So you'd have week 1, you learn about, setting up a triage for COVID. Week 3, you learn how to put on the PPE. So that was done and scaled down from as early as June, July last year. And then goes on monthly with once a month mentorships to sustain and strengthen the health system despite waves. It was a very interesting approach, but it was lessons learned from our local experience. And it was us talking to local partners and then getting buy-in subsequently from the development partners to fund such an effort. Within 3 months, over 20,000 healthcare workers were reached, not with the one-off trainings, but ongoing mentorships, picking up mentors from their own facilities or from nearby facilities, and using a single harmonized curriculum for infection prevention and control. So that's just one example of what can happen when local partners have been prepared to respond to local outbreaks. The second really has to do with travel. Once you have these outbreaks, you have restrictions to travel and trade. I know the international health regulation says we don't want those things to happen, but inevitably, if the outbreak is severe enough, that would happen. So about 2015, early 2015, I did get deployed to Sierra Leone, and I had to move from Uganda to Sierra Leone. It took me about 2 days of flying from Uganda to Ethiopia to Ghana to Ivory Coast. We had a stop up in Liberia before finally getting, into Sierra Leone, just because of the flight restrictions that had happened at the time. And so really, we want to see this workforce, local workforce capacity built. We want to see partners in country pooling resources and then reaching the places where they're already present. But I want to emphasize this about localization. We don't want to estrange ourselves from the international community. We don't want to estrange ourselves from technical support. IPC models, WASH models that were scaled up, these were developed, in coordination and in collaboration with colleagues from CDC and other places. We learn together, but then when trouble comes, those that are in country really need to run first. Thank
you. Thank you, Mohammed. I mean, just so many really important points that you've brought up there. I mean, firstly, as you mentioned, Ebola, the entire international community supported a response, but that was a localized outbreak. That was not possible in a pandemic where mass movement of people or mobilizing rapid response teams could actually help proliferate the virus and do more harm than good. So countries really were left to their own resources. But I think it's important, as you've mentioned, that localization doesn't mean a break between support with the international community, continued engagement there, lessons learned, technical assistance, but it really does mean investing in the health workforce, investing in people, and moving beyond one-off trainings and considering the importance of those in-person mentorships and real capacity strengthening. So thank you. Your experience between a deployment to Sierra Leone in 2014 and what you have been leading in Uganda in the COVID response, I think is really an incredible one, and appreciate you sharing those stories. Allison, let me shift to you and let me put a two-part question. Earlier in our discussion, when you and I were talking, you had mentioned that the economics of the market do not necessarily work during a crisis. Can you firstly help nonprofits like ourselves understand what you meant by that, what it means for the corporate sector? And then also, you're a member of the domestic, the HHS-led supply chain task force here in the US. And you talked about one of the major achievements was creating these data sharing platforms that helped you to proactively identify and address supply chain challenges, these data sharing platforms that previously didn't exist. Can you talk about why this was so critical in the response, if there was challenges in creating it, and are these things that we can utilize on a global scale?
Thanks, Chris. And Mohammed, just really extraordinary to hear about the work that you've done in Uganda and are doing in Sierra Leone. And was really struck by your comment. You said, so, when COVID hit, we were ready to go. And I think that points, Chris, to why we have been engaged in all of these public-private partnerships that I was describing before. So to address your question specifically, I think it's important to think through what are the supply chain risks, and that as kind of the foundation for why the economics and the market fails in a crisis, and how to mitigate that challenge. So, this group understands well that the supply chain for, healthcare products is not only impacted by pandemic, as we've seen, but natural disasters, geopolitical events, labor issues, shortages of raw materials. We know that the raw materials for many of the PPE products are very regionally based. So for example, much of the material that goes into nitrile gloves comes from Malaysia and Indonesia. 80% of the world's production of surgical masks comes from China. And relevant to the COVID-19 pandemic, actually much of that 80% of the world's production happens in Wuhan. And there's also all sorts of regulatory challenges that we face from a supply chain perspective, and any tiny localized issue can have cascading effects on the entire healthcare supply chain. So just to give a couple of examples, to start, this pandemic, we really hit a perfect storm that put just tremendous stress on the supply chain in the early months of the pandemic in getting critical PPE to all countries around the world. Not only is much of the production of masks in China, of course, the outbreak struck during Lunar New Year. And many of the factories closed down, and there was limited movement within China. All of a sudden, consumers, companies, not only countries and health systems, but just usual normal consumers and even companies were buying up massive amounts of PPE and really imbalancing the market. And all of a sudden there were changing government restrictions around movement of PPE around the world, which really caused huge challenges. Just a couple of other examples before I get to kind of that economics question you were asking. Last December, even just over the winter holidays, goods purchased for the holidays were jamming up the shipping space needed for healthcare products. And so there was not space on shipping containers to ship critical products around the world. Even tiny examples, like a key medical plastics manufacturer had a fire in their factory. Just as the vaccine distribution effort was beginning, there were concerns around the availability of Sharps containers. And right now, we're entering monsoon season in India and Asia. Obviously, the pandemic is raging. We're at the beginning of the Atlantic hurricane season. And all of this while we continue to see really heightened PPE needs around the world. And so, Chris, this points to the importance of partnership, and it also points to why kind of the market fails in these cases. Just to back up, you were speaking a little bit about the partnerships that we were describing. The Pandemic Supply Chain Network, which was founded at the World Economic Forum, really was founded in response to the Ebola crisis and the experience that not only the private sector, that the public sector had in really a lack of communication and coordination, and a real understanding that the critical supply chain for these products is fragile, and no one sector could possibly address these challenges alone, and that we couldn't first be getting to know all of the key actors in the midst of a crisis. And of course, PQMD understands that better than anyone, and the importance of these kind of critical long-term partnerships, and the trust that's built between these partnerships. From an economics perspective, why does the market fail? A lot of the reasons that I was describing before, there's a real regional reliance on particular raw materials. There's a basic math problem. If you have a lot of these healthcare products being manufactured in parts of the world where manufacturing is less expensive. If you try to diversify manufacturing, the prices will go up. Perhaps there will be an appetite to purchase those products in the short term, during a crisis or just after. But does that appetite remain? The market kind of always drives to those least expensive products, and so you really have a challenge in the market that really only can be managed by, and I hope later in the discussion we can really get into sustained investment, but we need to see sustained investment by governments, by international organizations, sustained investments both of financial resources and of human resources to put towards these partnerships to really manage the risks, and also sustained financial support and investment in health system strengthening. As Mohammed described, this can't be episodic. We need strong health systems. I'm reminded, Mohammed, as you're speaking, Dr. Tedros said a couple of years ago, I think at the World Health Assembly, global health security and universal health coverage are two sides of the same coin. And so I hope I got the quote right. I think that was right. But health system strengthening is really one and the same with building global health security. And so, sustained investment in one is drives the other. And so, one lesson I really deeply hope comes from this pandemic, which, I think the alarm bells had been sounded for many, many years prior, but it's very hard to get sustained attention and sustained focus. But I do hope that one of the results of this pandemic will be that the world has seen just the extraordinarily devastating effect that an outbreak like this can have, and that we continue to sustain investment. And honestly, we all know, as devastating and horrific as this has been across the globe, this is not the worst it could possibly be, right? I mean, we could have had, and we see with the variants, you can have a virus that's even more transmissible, more virulent, we need to heed these lessons and take them into the future in perpetuity, not just in 5 years and 10 years, but forever. So I'll leave it there. And Chris, happy to address any other questions about the partnerships or any of the other pieces as we continue.
Thank you so much, Allison. And if we have time, one of the areas I'd like to come back to is, some of the challenges you listed out wonderfully, all of the experiences we faced, the perfect storm of reasons why there was just a massive global shortage of critically needed items. I know NGOs like ours that work with companies like Henry Schein, we're extremely grateful for the product you were all able to donate, really massive amounts that we were able to use in the context of our programs. But one of the things that we all faced was all of the fraud that grew up in context, as you can anticipate, the profiteering that took place, the fraudulent products that put out, the massive confusion around the changing standards country by country of what the minimum standards were for a respiratory mask, for surgical masks, for the other items that were required, and just a huge amount of risk incurred, and some of it was very high profile with massive procurements of goods that ended up being completely bogus or fraudulent, fake companies being stood up. And as a member of Partnership for Quality Medical Donations, of course, that's really core to who and what we are. I'd like to hopefully have time to come back to some of that quality control issues, and if that's something that's being tackled by the the Pandemic Supply Chain Network. But you brought up an interesting point around the global health security agenda. And Mohammed, I know Uganda is a very active member in this. One of the tools of the global health security agenda, very important one, is the joint external evaluations, the JEEs. And these are voluntary, collaborative, multi-sector processes to assess each country's capacity to prevent, detect, and rapidly respond to outbreaks. Now, it seems there's some irony that the scoring of these JEEs for countries around the world had very little correlation to where the COVID pandemic hit the hardest. Mohammed, are the JEEs still relevant? Are they still an important tool for us as we look to strengthen country capacities? Can you speak to that, please?
Thanks very much, Chris. Just to say before I answer, Allison, that I'm so relieved to know that there is somebody really thinking around these global supply chain issues. I think one thing you didn't mention about the market failure is many of the small countries really don't have the capacity to really, prepare and organize large-scale procurements. They may not have enough resources to be taken seriously by suppliers. Also, they may not have enough resources in terms of planning and benchmarking and quality, as Chris has mentioned. And knowing that, that there are international groups thinking about it, pandemic supply chain networks, those are things that bring a lot of relief to me, knowing that Uganda is now entering, unfortunately, a hospital phase of its outbreak. In the last 7 days, all our ICUs, for example, in Kampala are full, and they've been empty for months before that. So really, we do need that type of support, coordinated support, ensuring that good products get to countries with minimal resources. Now, the JEE, the JEE has been the evaluation tool that we've used to measure countries' progress to the obligations that they have, because these countries have signed up to the international health regulations, and then they become member parties to the World Health Organization. So these are solid frameworks that have really, been used and understood by various countries. But it's a tool about capacities, not about how those capacities are actually being used. And it gives us those technical areas that we should strengthen the system, in our respective countries for. It shows us our gaps. It allows us to create what we call national action plans for health security. Now, each country can look at that national action plan for health security, they can look at their JEE scorecard, they can then build and close those gaps. Now, how those tools that have been given to us or that have been invested in are used in outbreak, that is the scope of leadership. In Uganda, we were lucky, we've had good leadership for outbreaks. We've had presidents, for example, leading risk communication. We've had ministers of health who are actually experienced in outbreak response themselves. And so they know when to move and when to ensure that they bring partners to provide additional support. So it's not about throwing away the baby with the bathwater. It's not about throwing away the JEE. It's about continuing with the JEE, but then looking at this concept around leadership during outbreaks and looking at how we can better prepare leaders at all levels to use the tools of the health security system in their country to their greatest advantage.
Thanks so much for that, Mohammed. Appreciate that. There's a lot of questions coming in the chat. I'm not sure if we can get to all of them, but Allison is one I really like this, and I'm not sure if you've got the answer to, but would love to hear your perspective. And it's about the numerous stories we heard about local innovations to solve supply chain challenges from countries that are non-manufacturing countries that didn't have their own national supply that they could serve their own populations and had to become innovative and had to pivot on this. Has this approach, has this mindset inspired any lasting supply chain changes to tend towards more localized solutions with the global supply chain?
Yeah, no, I mean, it's a super interesting question. And, look, like, fabric manufacturers, clothing manufacturers started to make pivot to making masks. It's quite extraordinary, from a PQMD perspective of quality control and ensuring the effectiveness of the products. I think, first of all, that's critical, and depending on how the products are used, if they're used in a healthcare environment, or if this is for sort of general protection for the population. I think, but I think these kinds of innovations are really critical, and I think as we go forward, we're going to probably see more, and I think we're going to see, Mohammed, you were talking about the challenges that smaller countries face in terms of even procurement. One of the things the Pandemic Supply Chain Network has been working on for the past 6 years and continued over the course of this pandemic is to both facilitate the data sharing between the private sector and the and national governments and multilateral organizations, and also provide support for a UN procurement mechanism that supports smaller countries that you're describing, Mohammed. So it almost, the hope is that it could almost act like almost like a wedding registry where the products that can be accessed are on the one hand, and on the other hand are the needs put forward by countries. So I'm not, I guess, directly addressing the question around innovation, but I think it's critical. I think diversification of the supply chain is clearly critical. And I think we're going to continue to see more of that. I wanted to respond, Chris, if it's okay, to something that Mohammed was talking about with the joint evaluation exercises. And I wanted to just note, actually, the MOU that the Global Health Security Agenda Private Sector Roundtable has with the Ministry of Health and Government of Uganda was really around these JEEs. And just to give one small example of sort of how the private sector can contribute in a tangible way, in even that example, the Private Sector Roundtable worked to develop data platforms for countries to be able to put in, to be able to see how they've done on the JEE across the board, and to really identify where there are gaps, and then to be able to see where there, how progress is happening over time with respect to the scoring of the JEEs. And so, we'll see, I think, over time how JEEs evolve. But I think that, there's no question that as much preparedness and focus as we've given over the many years to what would happen in this kind of scenario, I think we've had a lot of learnings over the past year that will apply going forward. So hopefully we will all be in a better position the next time.
I love the positive attitude there, Allison. I think we all want to make sure that we translate so many of these lessons learned into real action. And frankly, I think the knowledge and understanding is there. We've been screaming as a collective community about the threats that exist, but now the political will hopefully will back that up, and we'll get the resources we need. So, Mohammed, there's one other question.
I would say we have to keep on screaming, because I think the political will is there in this moment. The political will will be there in 2 years and 5 years. Let's keep screaming, because it inherently, urgency devolves into amnesia, which is, I'm borrowing a quote from Laurie Garrett, but we cannot develop amnesia in 5 years and 10 years. We need to continue to scream and sustain these investments to protect the world from how we failed in this moment. So sorry, Chris, to interrupt.
No, it's an excellent point, and it's an excellent quote. I'm going to try to make a mental note if someone doesn't put it in the chat as I'm talking. Mohammed, there's one other question in the chat. It's kind of broad-based, but PQMD is this unique grouping of both international NGOs and corporations working in this space. And the question is, can you talk about the best ways INGOs and corporations can simultaneously help local partners with outbreak preparedness and health system strengthening? You mentioned the continued importance of this international engagement in spite of efforts around strengthening local healthcare systems. What is that role as you envision?
So thanks for that question. I actually started trying to type a quick note into the chat for that. Local organizations need to take the lead in their own strategic planning. INGOs can point local organizations to that and in that direction, and provide them with support in their own, strategy development. They have to really look carefully and say, we already have investments and skills in this area. We already have personnel that have been trained to point X in this area, and this is what we can handle. Because the issue with outbreaks and emergencies is that then, you come into this whole personnel safety and health and safety issue that not all organizations might be able to, might have the appetite to take on at once. So those local organizations that are willing should have their strategic plans developed. They should identify the personnel that have been skilled to a certain point. International NGOs can then build on those on those assets and move forward. The way I want to look at it when we say health security and health systems should be, on the different sides of the same coin, is that health security really should be, the bottom facing part of the coin. You should have health security first in terms of the people who are going to work on malaria, TB, HIV must be trained on what they need to know and how to detect an outbreak early, and then build further on that to give them the skills that they would use on a day-to-day basis outside outbreak. And then during emergencies, then they can be brought on as surge teams. That's really the way we would like to see this working in a more sustainable way.
Excellent, thank you for that, Mohammed, and glad to know there's still a role for us. It's a very dedicated group that we have here. Allison, coming back to the data point, you mentioned some important progress made. Is that the direction we're going? Is that the direction we have to go if we want to be more prepared?
Yeah, I think one of the great advances that we've seen through these various partnerships. So, it's describing the work of the Pandemic Supply Chain Network, and even just as a domestic example, the HHS, Health and Human Services Supply Chain Task Force. These initiatives have built these really critical data sharing platforms to enable sharing of very sensitive information. Sharing data in a sustained way is not easy. There are you need to develop governance frameworks around that. You need to develop legal structures and other frameworks that really enable the sharing of sensitive information across private sector entities and the public sector. No one entity has the complete picture into the supply chain, and without as good a picture as we can get in market capacity and where there may be challenges arising, we need the full picture to really understand how to address these challenges and work to try to avoid that perfect storm in the future. So these and not to mention, so you have the governance issues, the legal issues, but you also have the trust issues, right? And it takes a long time to build trust across partners to really be able to share information in that way. We have made such important advances. We can't lose those advances and then end up in a situation where we have to reinvent the wheel in the future. It's critical that these initiatives continue, be sustained in the long term. So when we were talking about sustained investment, it's both financial investment and it's also, investment in time and resources in these kinds of partnerships to continue to to share information, because from a supply chain perspective, data is and information is the most critical tool, or one of the most critical tools we have to solving these challenges, so that we don't end up in similar in a similar situation in the future. And I just wanted to say one other thing with respect to health system strengthening that I was thinking about as Mohammed was speaking. In this moment, as the world gears up to distribute the COVID-19 vaccine, and there's lots of money being put into COVAX and other initiatives, we have a long way to go with distribution globally, and that's really just beginning. But as money begins to flow into these efforts, we really need to think about how to ensure that investments are made in a way that sustains health system strengthening, and we're not standing up, one and done vaccine, initiatives that will not, feed and strengthen health systems overall. There may be some, the need to do some of that, but I think as much as we can, as much as international actors can think about really using this opportunity to invest locally and in local partners, the better will be from a health system strengthening perspective.
Thank you. And I couldn't agree more. I feel like that's one of the really important lessons learned, where so much of our response mechanisms globally have been fixated on how do we mobilize international supplies, human resources, technical assistance, cash to crises areas. And yet when the crisis becomes global, that model simply doesn't work, as it didn't in COVID. Just quickly, we're right at the end of time. The data sharing, that it's such a huge breakthrough, I think, in a lot of ways. And your companies are obviously, there's competition exists in this space. It's the same thing on the NGO side. We don't like to talk about it because we like to be driven by our humanitarian principles, but in fact, there is a lot of competition, and it has to be recognized. In fact, much of the humanitarian architecture that exists is designed to help individual organizations, UN agencies, and others drop their individual mandates for the collective good of the response. And it's something that is better addressed head on rather than pretending that it doesn't exist. When you're talking about sharing data to improve a global response effort around the global supply chain, do you find resistance with other companies that are looking out for their personal and corporate interests rather than the global good of maybe more globally minded ethical companies?
That's a good question. I think, I think we have, given the enormous global imperative, moral imperative that we're faced with in this pandemic, companies really, in my experience, came to the table in a very open way and willing to share data and information. And part of what's critical in these sharing platforms is to ensure that you can, you have a central repository for data where, everyone's sharing data. It goes into sort of a central repository and then gets shared out back to the fuller group, and so no one entity is at risk for sharing their particular. You sort of provide some anonymity. The word I'm trying to say.
I know what you're trying to say. I'm not going to try to say it for you.
For data, I mean, there are ways to do it that do protect each of the entities, and I think that's part of what has been really innovative during this pandemic, and in what we're trying to build leading up to it. Of course, there are going to be some entities that are not interested in engaging, but I think overall, as a whole, the private sector has really shown that folks are ready to come to the table and share, and obviously within what's possible and from a legal and confidentiality perspective, but my hope is that will continue in the future, as we said, because it's going to be really important to continue to identify where there are little blips in the supply chain that we can, target quickly to ensure we don't have
it's incredibly encouraging. And I know so much of it is toned from the top from leading companies rather, like Henry Schein. So thank you for your leadership in that space. Colleagues, we are right at the end of our time. I did not allow time, forgive me, that's on me for closing comments. But I do want to give just a huge thanks to Allison and Mohammed for their contributions today. Again, they're readily reachable. Their bios and contact information are available. We could continue this conversation for hours. There's so much to dive into, but thank you both so much and for everybody's engagement here today.
Thank you.
Bye, guys.
Thank you.